Good afternoon, everybody. It's my pleasure to be among those distinguished speakers today. So my talk is about precision of medicine. I will highlight more, emphasize on the medical oncology aspect, which is shifting paradigm and cancer treatment. I'll fly through my slides because I have, I think it's I have few slides. So this is just to show you that the cancer is a worldwide burden. This is from Global Cancer Incidence 2017. There were 14 billion cases of cancer diagnosed worldwide. Half of those, unfortunately, passed away. In Bahrain, the most common cancer in males, it's lung, followed by colorectal, then prostate. In females, it's breast, followed by colorectal and cervix. The good news, there was a significant drop in the incidence and started from 1991, and this is likely because of the new treatment options based on the knowledge of molecular medicine or personalized medicine that I'm going to go through in a minute. So this is just an introductory slides. So when we treat a cancer, we would like to cure if we can, or to prolong life. However, there are certain situations we only aim to improve the quality of life of the patient. So when we deliver any treatment to the patient, we have to balance this, the symptom of the progressive disease and side effects of therapy, which is very important. So what strategies of treatment we have? We have the old strategies and treatment modalities, and we have the new modalities. So what is the standard or the old treatment modalities? We have the well-known chemotherapy, which is the cornerstone treatment for many of the cancers. However, it's very toxic with substantial toxicity and not really, we don't know who will respond. And many of the patients will not respond, especially in solid tumors, unlike the hematological cancers. So traditional therapy, chemotherapy, i.e., it has some disease control variable among the different populations and improved quality of life. However, we have substantial toxicities and certain benefits, and we don't know. The benefit is limited to certain patients, not all will benefit. Okay, this is a very important slide. This figure, you can see the highlighted individuals. Those represents the person who will not respond to any given treatment among the population. So you can see the very last slide, the cancer drugs will not work in 75% of the population. And it's not only cancer drugs, other also group of drugs. The number or percentage of patients will not respond is significant. We cannot ignore. What does this mean? Why drugs fail? Drug fails because when we treat the population, it is an unselected population, among which you can see those highlighted population, which are the favorable group, and the highlighted in red, who are the unfavorable group. So among the favorable phenotypes, those are the patients who are sensitive to the treatment, who will respond very well, and they have already decreased cancer risk. Whereas the unfavorable phenotypes, those patients will not respond, even if they have the same stage, same type of cancer. And they have substantial toxicity, and already the risk of cancer is more than the other populations. So we need to know different tumors have different biomarkers. Those, I have given an example, 2 of my patients I have treated, exactly matched for the stage and type of breast cancer. We treated with neoadjuvant chemo, so you can see the slides on the right. This is the tumor before treatment, and the second slide next to it on the left, complete response. The tumor has disappeared after the neoadjuvant chemo. However, the other patient matched, as I said, same type and same stage. This is the scan before and after treatment. There was no response whatsoever. Same treatment that I received. Why this happened? Because we know that cancer has different underlying molecular interactions. At the genetic level, it's complex and diverse. It's not only one type. This is an example how the knowledge has evolved in breast cancer. In 1900, we classified breast cancer only based on the microscopic appearance to grade 1 and 2. We knew from the history, grade 1 is favorable, they live longer, and grade 3, the patient usually don't respond to the conventional treatment, and they have widespread metastasis, and it is more aggressive. Why was that? As the years passed by, we learned that in the molecular level, they have different genetic control. We knew that the breast cancer will be classified not only based on the histology, also we have the molecular gene, ER, PR, HER2. Those are the hormone receptor, estrogen, progesterone, and HER2. And those, based on this, we knew which treatment is best given to which group, and which patient will need genetic risk assessment. Who, like triple negative cancer, we have to do the genetic germline mutation. Most of them are BRCA positive. Whereas, and we know those patients will not have, they will not respond to treatment, to hormonal treatment. They need chemotherapy and PARP inhibitors or something to target the mutated genes. And the other subtypes of breast cancer, like HER2, luminal, we knew. Luminal is the excellent prognosis, which equals the grade 1 cancer. They respond very well to hormone. They don't need chemo most of the time. The other group, HER2, they need their own treatment, which is monoclonal antibody directed to the HER2, not only chemotherapy. So the more we know, the better is the outcome of the patient. So there we go. What are the strategies to improve cancer effectiveness? It is the concept of personalized cancer therapy. What does it mean? We want to study the tumor, both the tumor and the patient characteristic, to intelligently find the right treatment for each individual patient. As we said, one size does not fit all. Each patient has a different tumor and needs different treatment. Better treatments are less toxic and more specific. Exactly what I try to explain this slide. So chemotherapy hits blindly, substantial toxicity, whereas if we can find a target to hit, which will give better response and less toxicity. Okay, so as we said, advances comes in two flavors. We want to identify the people or the patient who will benefit of the treatment we are going to offer, and we want to find who are the patient who will respond maximum. This is, again, I'm just trying to emphasize that personalized medicine is driven by both histology and genetics. We have to integrate the knowledge, the genetic advances in the genetic knowledge we have today. Okay, this is an important slide. Personalized medicine is also known as precision of medicine or individualized medicine. It integrates personalized medicine. Basically, the concept is the use of the biomarker, which to identify which treatment works for each patient. What are biomarkers? As we know, it is a characteristic that can be objectively measured, which can be an indicator of normal physiological process, pathological process, or pharmacological response to medical intervention. In real life, we have to combine the data from the biomarkers we have with the patient clinical scenario. How fit is the patient? What is his preferences? So we can come with the best treatment plan options for best outcome, and even for preventive plans. This is what types of markers we have. We have predisposition markers that we can use in our preventive and prophylactic measures, BRCA1 and 2 and other genes. Diagnostic markers, like we use in hematology, Professor Tharwat probably, in CML and other BCR-ABL gene, which is important to diagnose certain leukemias. Prognostic index, oncotype DX, who is the patient with aggressive feature who will need chemotherapy for breast, and we can spare from chemotherapy. Predictive markers, which treatment is best. So those markers predict response to the antidote for those markers. So HER2 positive, we need to go to give anti-HER2, ALK inhibitors, EGFR inhibitors, according to which marker represents in the cancer. Okay, how can biomarkers testing optimize the treatment care in oncology? Because we can get the right diagnosis, the correct treatment, and the correct dose. So biomarker testing identifies subgroups of patients whom the selected drug is most effective and safe. I'm giving I will fly through those slides. This is just examples of how molecular biology changed the practice in treating cancer, especially lung cancer. Lung cancer is one of the aggressive cancers. As we all know, we had no, يعني, a patient presents with advanced stage lung cancer, the survival before was 6 months, best case scenarios 1 year. Now, with the new drugs, they can live up to 3 years. Metastatic setting, talking about. So this is lung cancer. In 1986, we thought it's only one type of cancer. In 2015, 7 molecular drivers were identified. This is just to explain to you that overall survival of the patient has improved because we have more treatment to offer. Patients were not living long before, we had no options except palliative care or radiation. More drugs were interviewed associated with prolonged overall survivals. So over time. This is just to show you active treatment has prolonged survival compared to best no treatment or best supportive care. Maximizing the benefit from chemo, this is example, in lung cancer. So in lung cancer, we treat based on the histology and molecular markers. From the studies, will not go into the details, we knew which treatment works for lung cancer. We know cisplatin is superior to carboplatin combinations superior to non-platinum combinations. And then, as I said, it reflected in prolongation of the survival, chemo only, about 8 months. More advances and prolongation of survival because now we know the trial has shown that certain chemotherapy in certain histological subtype, adeno, pemetrexed-based treatments, squamous, Gemzar, and those the graph shows clearly the separation of the lines and the overall survival and progression-free survival benefits. So even in maintenance, adenocarcinoma, different drugs. We'll just go to, okay. Now the role of molecular pathology is very important. When we want to treat, this is the NCCN guidelines, when we want to treat a cancer, lung cancer patient, newly diagnosed, metastatic stage, we have to follow the guidelines, which is clearly shows that we need to know the histopathology. Is it adeno or squamous? And after that, we need a panel of molecular marker, usually needed for non-squam, because the mutation are more non-squam, or squam who are not smoker. I mean, mutation are different. The targeted mutations, which we can target more in non-smokers. In a smoker, they have different mutation, more different mutation. Not all of them are targetable. So I'll show you in the coming slides. So this is the knowledge, have the knowledge evolved from 1980. How many markers in lung cancer we have identified? Many markers, most of them have drugs, targeted drugs for them. Okay, so this is just to show you how many, again, just to show you how heterogeneous lung cancer is, and we cannot apply the same treatment for different patients. This is a story of success because most of those mutations have now targeted drugs. So this slide just shows that. Okay, another success was when they discovered the TKIs for lung cancer, and this showed that TKIs is superior to chemotherapy in patients who has the mutation, EGFR mutation. Clearly, the graph shows this, and the graph on the left shows that the drugs work on those who harbor the mutation, not the wild type. More drugs, more TKIs showed more survival benefit and progression-free survival. Newer drugs with significant prolongation of the median progression survival reaching more than almost 18 months. Never happened before. With the first line, it was 10 months, with chemo 8 months. Now we are reaching up to 19 months. Other genes and targeted therapy, those are common genes for medical oncologists, and we treat. So ALK mutations and the drugs for the crizotinib and alectinib, newer drugs, more effective, significant prolongation of the progression-free survival and incidence of CNS metastasis. Okay, immunotherapy. This is another success story when the introduction of immunotherapy in cancer treatment. So the discovery of immunotherapy and application of immunotherapy was a story of success. It has shifted paradigm in cancer treatment. And the idea or the concept of immunotherapy is just instead of targeting the cancer, we will target the immune cell. I will show you in a minute in a slide. And to know who will respond to the immunotherapy, we have biomarkers. The biomarkers for immunotherapy, PD-L1, mutational burdens, and MSI. So we have to check for these in the pathology specimen or blood test, and if they are positive, we can hit those. So the basic idea, there is normally the T cell receptors will recognize an antigen on the surface of the cancer cell. The immune system has very important role in fighting cancer. So most of the patients will say the immune compromised patients are more prone to cancer because the immunity has something wrong with the immunity, and the tumor cell intelligently will produce a protein, a ligand, we call it programmed ligand. It will bind to the receptor on the T cells and inhibit the recognition. So the immune therapy will attack this interaction. So restoration of the function of the immune system. So if we have the marker, we need the expression of the marker, which is PD-L1. The higher the expression, the more the response. Story of success. And second line lung cancer, we had nothing but docetaxel with minimal improvement in the overall, a few months. The introduction of immunotherapy as a second line was really a story of success. You can see the median survival from 8 months to 20 months. We've never seen that before. Okay, and you can see it. The more the expression, the higher the response and the survival benefit. So we have, this is all, many study has been done, and just to show you that even those slides, even front line, first line, they prolonged, and very promising in first line immunotherapy for lung cancer. So this is a take-home message. Biomarkers are features that represent mechanism of action and resistance of drugs and allows to improve efficacy of the intervention or therapy. Treatment paradigm are evolving because molecular characterization of cancer and agent to pick the best fit. Realization that the population with cancer are not the same. Realization that each cancer type is quite heterogeneous. So our strategies to improve cancer treatment effectiveness, the trick is to pick the right target and the right agent, and then the right pairing. Thank you very much.